Good morning, everyone. Welcome again to our E&M Snow Day Activity Inpatient Services webinar. My name is Ashley Decoto, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who you just heard from. Leanne is going to be helping out with the chat. This webinar is part 2 of our 2-part series on E&M inpatient services. Yesterday, Leanne held the part 1 webinar, which provided a more comprehensive overview of inpatient hospital and observation care guidelines. If you were not able to attend her session yesterday, that recording will be available within the next week or so in the training center of our website and also on our YouTube channel. We will also have a recording of this session available in the training center on our website, and Leanne will be adding a link for the training center to the chat. It will be available on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can actually access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube at work. The recording will also be available on our YouTube channel, and it will stay there as long as the information remains relevant and current. Also in our training center, you can find a copy of today's presentation. So if you've not already grabbed that, it is still available for download if you'd like to have the presentation to maybe follow along or take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. And I will check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have a number of questions that were pre-submitted with registration, and I'm going to be answering those throughout the presentation today. All right, for our agenda, we'll start by doing a brief recap from Leanne's Part 1 webinar yesterday. Again, if you were not able to attend that, we encourage you to review the recording from the Encore page on our website or on our YouTube channel once those become available. After the Part 1 recap, I will be sharing the top denials and rejections for inpatient services. Then the remainder of our session will be our interactive Q&A activity. This webinar will be covering the professional billing of these services, not the facility billing. Also, before we get started, we did have a couple pre-submitted questions asking if we had any updates. We do not have any updates necessarily on inpatient E&M services to share, but again, I will be providing our top denials and rejections based on some recent claims data. This slide contains the acronyms that I'll be using today, and I've gathered these all in one place so that you have this for reference. Some of you may be familiar with these, but I did include these as we may have some attending that are a little newer to billing Medicare and maybe not as familiar with these. If you've not already downloaded the presentation, again, that is still available in the training center on our website under live events. So feel free to download that so that you have this acronym slide as a reference. All right, let's start with a quick recap of Leanne's session from yesterday. So first on this slide, we have the CPT codes for hospital inpatient or observation care. Your initial codes are listed first, which are 99221 through 99223. And then we have the subsequent hospital inpatient or observation codes, 99231 through 99233. Excuse me for just a moment. I apologize, I had a bit of a tickle in my throat. So these codes here, they're used for both hospital inpatient and for observation. Keep in mind that observation status is still considered outpatient for Medicare. So for observation care, these codes are billed only by the ordering physician, meaning the physician who has decided that this patient needs to be under observation. and is the one who is primarily responsible for that patient's care and observation. All other physicians, such as specialists that may be asked to see the patient during the observation stay, they would bill using the office or other outpatient codes 99202 through 99215. We did have a pre-submitted question asking about the difference between 99232 and 99233. So these are both subsequent hospital inpatient or observation care codes. 99232 requires a moderate level of medical decision-making or a total time of at least 35 minutes. 99233 requires a high level of medical decision-making or a total time of at least 50 minutes. For whichever code you choose, either by time or by medical decision-making, make sure your documentation supports that level of service. All right, next thing we have here is that these services are per diem services, meaning you may only bill one per day per physician or physicians in the same group of the same specialty. We had a pre-submitted question that asked about more than one visit per day. If you have more than one visit per day by either the same physician or another physician in the same group with the same specialty, you would combine that documentation and bill for just one visit using either time or medical decision-making based on that combined documentation. You may bill for prolonged care using code G0316 when you exceed the time for the highest level of service by at least 15 minutes. And we'll look at prolonged care in a little more detail during our Q&A activity. So on this slide, we have part 1 review continued, and here we have some information on discharge management. We have CPT code 99238 for 30 minutes or less for discharge stay management, or 99239 for more than 30 minutes. 99238 and 99239 are time-only codes. You are not able to use medical decision-making for these codes. And these codes are also the ones that are used for pronouncement of death. Now, if you have an admit and discharge on the same day, and the length of stay is at least 8 hours, you would use codes 99234 through 99236. These codes for same-day admit and discharge may be selected using time or medical decision-making. And again, we're going to look a little closer at discharge stay management during our Q&A activity. All right, next up, I want to share what our top denials and rejections have been at WPS for inpatient and observation services. And these denials and rejections are based on claims data that I pulled for those inpatient and observation care codes and the discharge management codes that I shared on the last 2 slides. So let's take a look at our list here of top denials for inpatient services. First on our list is claims denied while the beneficiary is in a period of managed care. And this would happen when they're enrolled in a Medicare Advantage plan. So make sure to check eligibility, which is something that you can do through our secure portal if you're signed up to use that. And if the patient has a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare does not process those claims. Next on our list is duplicate charges, which might happen if payment was already made to you for an inpatient or observation service for that patient on that date of service, or a claim is already in process. Now, if you believe your claim denied duplicate and error, you may submit an appeal. And wanted to note, duplicate charges continue to be one of our top denials kind of across the board for E&M services. So you want to make sure that your billing system is not set up to auto resubmit for your Medicare claims. The third one on our list here for inpatient service denials is expenses incurred prior to coverage. For this one, make sure that you're checking their entitlement date, which you can find on their Medicare card or in our SecureNet Access portal if you're using that to check eligibility. The next denial on our list is claim adjusted due to billing error. And this one might happen if you've reopened your claim and the claim reprocesses but still denies. So maybe you're correcting a minor error through a clerical error reopening. You could be maybe correcting your place of service, for example, but then the claim still has reason to deny, maybe because it's missing a modifier or has an invalid modifier. Our last top denial for inpatient services is expenses incurred after coverage terminated. And this one could happen if maybe your patient had Part B coverage last year in 2025 and then elected not to receive Part B coverage for 2026. So services this month would give you this type of denial in that situation. Maybe they're still working and have decided they can't afford to pay Part B premiums in addition to their group health plan. This denial could also occur if your patient was on Medicare because of a disability, but they no longer qualify as disabled. So you'll want to make sure that you're verifying eligibility to confirm that your patient has active Part B coverage. So when your inpatient service codes deny, your next step for these will really depend on the type of denial that you receive. And your remittance advice will really be your best source to determine what's next. It may indicate you need to resubmit your claim, in which case you can correct the error and then resubmit. In some cases, you may be able to correct a minor error through a clerical error reopening using our SecureNet Access portal. So this might be to correct a keying error for your place of service or your procedure code, for example. And then you'll have denials that will require you to appeal if you disagree with a claim determination. And your remittance advice would include remark code MA01, which indicates that you do have those appeal rights. So we'll move on to our top rejections for inpatient services. For rejections, you'll fix the error and resubmit the claim. So keep in mind that for rejections, the claim was not able to fully process, meaning a claim determination was not yet made and the claim does not have appeal rights. These must be corrected and resubmitted. So the first rejection here is claim lacks information needed for adjudication. So something is missing from the claim. And you'll look at the other reason codes on your remittance advice, which will give you a little more information. This could be any of the items required for a claim to process, such as the patient's date of birth or your place of service, for example. So you'll want to double check your claim form and make sure that all of the required elements are included and resubmit your claim. For our second rejection, we have rendering physician number invalid or missing. And for these, it may say denied on the reason code, but this is actually a rejected claim. Also, in your remittance advice, the reason code actually says to submit a new claim, which is exactly what you would do here. Double check that you've included the physician's NPI and that it is the correct NPI, and then resubmit that claim. All right, next on the list is claims for those beneficiaries who have railroad Medicare. And those claims must be submitted to the MAC, or that's the Medicare Administrative Contractor, who processes railroad claims, and that would be Palmetto to submit your railroad claims. You can verify that the patient has railroad Medicare by checking their Medicare card, which would show Railroad Retirement Board and a red strip that goes across the bottom of their card. The fourth rejection we have here is incomplete or invalid information for other insurance. If your claim is rejecting this way, you may want to check item 11 on your 1500 claim form, which is a required field. You must include other insurance primary to Medicare in this field. If there is no insurance primary to Medicare, enter the word none. Leaving that blank on a paper claim form will cause your claim to reject this way. Now for your 837P electronic transactions, make sure you are including the primary insurance policy number. If there's not insurance primary to Medicare, you would just leave this blank for your electronic claims. All right, our last top rejection for inpatient services is place of service conflicts with the procedure code. So if you're billing one of the E&M inpatient service codes with a place of service 11 for office, for example, your claim will reject this way. You want to make sure that you're using the correct place of service for these codes. So for inpatient hospital care, you would use place of service 21. Now for observation, again, these are outpatient services, so you'll want to use place of service 22 for outpatient hospital when you're using these codes to bill for observation care. All right, now we're going to shift gears into our interactive Q&A activity. And we've designed this to be kind of a fun way to test your knowledge. So we'll be launching a poll for each question. Even if you aren't 100% sure on the correct answer, we'd love for you to participate and give it your best shot. I'll give you a moment to lock in your answers, and then I'll walk through the correct answer for each question. Leanne will be adding some reference links to the chat, and I will be briefly highlighting some key takeaways from these resources as we go, but I encourage you to bookmark each of these to review later. And a few of these may be things that you saw yesterday in Leanne's session, if you were able to attend that one, but we do want to make sure that you have these handy for our activity today. Right. So our first question is, time or MDM may be used to choose level of service for inpatient hospital services 99221 through 99223 and 99231 through 99233. True or false? I'll give you just a few more seconds. All right, it looks like just about everyone has their answer locked in. The answer here is true. You are able to use either time or medical decision making for those inpatient or observation care codes. Now, we also talked about the discharge management codes when I did the review of part 1. For the discharge management codes, 99238 and 99239, remember you're only able to use time to select your level of service. So these are the codes used for discharge management when the patient is not admitted and discharged on the same day. For the same day admit and discharge, when your length of stay is at least 8 hours, we use those codes 99234 through 99236, and you are able to use either time or medical decision making for these codes. We had some pre-submitted questions on documentation for inpatient services. Your documentation must support, first, that the service was medically necessary, and must support the level of service chosen. I want to go out to our website, to our Evaluation and Management Services page, which is the first of the links in the chat for this activity. So this page on our website is dedicated to all things evaluation and management. We have links for the CMS E&M resources up top. Then there are the relevant CMS Internet-only manual sections. We have several pages linked under WPS resources, including a few that are specific to documentation that I want to point out. There's this documentation to support an evaluation and management service under TPE review page that I encourage you to take a look at. And the one I find most helpful is this evaluation and management documentation webpage. And actually, we're going to go out and take a quick look at this one. So this page provides some general principles of documentation that apply for evaluation and management services, as well as some common issues that have been identified with E&M documentation. We had a couple questions on documentation, which asked how to handle copy and paste from previous visits, or we've also seen this method referred to as carrying forward information. And the answer to this is actually addressed on this page in the fourth bullet here under the common issues identified. So CMS does not prohibit cloning from a previous record, but we caution providers to ensure that the documentation from that encounter accurately reflects what occurred in that encounter. So we need to have documentation from the encounter itself. Are the clone notes from one encounter being used to document the services for a different encounter? And if they are, how is it documenting the current encounter? Because we would guess that the same thing did not happen in both encounters. So this can lead to inaccurate documentation. So again, be very cautious in using this process. Make sure that the documentation is for the encounter that's being billed. Also keep in mind for your subsequent inpatient services, the documentation must stand alone, meaning you cannot just copy and paste everything from the initial encounter. The documentation must show what was done that way, that day. All right, let's head back to our activity and on to our second question, which is, which of the following codes is used to report prolonged care time for inpatient hospital services? And our choices are A, G0316, B, G0317, C, G0318, or D, prolonged care is not covered for inpatient services. We'll give you just a minute to lock that answer in. All right, looks like we have lots of participation. I'm going to give you just a few more seconds. All right, so the answer for this one is A, G0316. I want to go out to the second link in the chat for this activity, which is the E&M Services Guide. So here's the E&M Services Guide, and this is a great resource to reference for really all types of E&M services. I'm going to scroll down to the second page where we have the table of contents. Notice right here, there is a section specifically on hospital inpatient or observation care. We also have this section just below that, which I'll click on now, for prolonged hospital inpatient or observation care services. So I want to point out this section because CMS does not follow CPT guidelines for prolonged care, so it's really important to make note of these guidelines. CMS has established thresholds that are not the same as CPT guidelines, and we'll look at those thresholds in just a minute. So right off the bat, we see here on page 13 that prolonged care for hospital inpatient or observation is billed with code G0316. There's this hyperlink that I want to take us out to for prolonged services, and this will take us to the section of this manual specific to prolonged care. Now here, this first paragraph here just gives us a quick summary of prolonged care. What I want to show you for this question is on pages 17 and 19. So I'm going to scroll down to page 17, and there's a chart for prolonged office or outpatient services. Now I know our focus today is on inpatient services, but remember for observation, only the ordering practitioner can bill the hospital codes, and any other practitioners involved in the care of a patient in observation would bill with the outpatient codes. And this is where you would check if you have enough time to bill for prolonged care for outpatient services. Now, another thing that's really important to look at in this guide, I'll find if I scroll down to page 19, this chart provides the thresholds to bill prolonged care for E&M services other than the office or other outpatient codes. So right up top, we find that to bill prolonged care for an initial inpatient or observation visit, G0316 may be billed only if you have at least 90 minutes. For subsequent visits, you need at least 65 minutes. Notice in the last column, time for your prolonged care may only be counted on the date of the visit. Just below the subsequent inpatient or observation, we have our same-day admit and discharge code 99236, which Medicare requires at least 110 minutes for prolonged care. Another reason this one is important to point out, check out the last column over here. Time for your prolonged care can be counted on the date of the visit and up to 3 days after. So what does that mean? Well, the time you're using to select your level of service for the same day admit and discharge may only be counted on the date of the visit, but the time to meet the prolonged care threshold can be counted from that day and up to 3 days after. So you might include non-face-to-face work for that visit, such as documenting information in the medical record or care coordination when it's not separately reported. All right, I'm going to head back to the presentation, but feel free to keep this guide up for some of our other questions. All right, our next question is, Medicare will only pay you for one hospital visit per day for the same patient, even if the problems treated aren't related. True or false? All right, it looks like most everyone's gotten their answers, and it looks like we're kind of split down the middle on this answer. So the answer here is true, and this is something that's actually listed in that E&M services guide that I took us out to on the last question. So if you have a single physician or multiple physicians who are members of the same group and same specialty providing care for the same patient or on the same day, you would combine their documentation and bill for just one service. Remember, if you're using time, you have the option for prolonged care if you meet the time thresholds that we looked at on the last slide. All right, our next question is a scenario. Dr. Gary provided initial care for Patty patient in the hospital continuously from 11 p.m. on 12/9/25 until 12:30 a.m. on 12/10/25. How is this billed using time? And our choices are A, 99223 with date of service 12/10/25, 99233 with date of service 12/9/25, 99223 and G0316, date of service 12/9/25, or is it D, 99233 and G0316 with date of service 12/10/25? All right, it looks like a lot of you are getting this one right. A few more seconds. All right, so the answer here is C. They would bill for the initial care code 99223, and they have 90 minutes, which meets our threshold to bill for prolonged care, G0316. The date of service is 12/9, since that is when the service began. We did have a pre-submitted question which said, calculating information on how to determine code level. So you'll choose your level of service based on either time or medical decision making. We aren't going to focus on level of service during today's webinar, but Leanne did a webinar just a few months ago on choosing your level of service, where she included details on both time and she went into the elements of medical decision making. And I have asked Leanne to place the link to the encore recording of that webinar in the chat. All right, our next question is, you may only bill one initial or subsequent hospital care code per day. True or false? Leanne, I don't show that that one has launched.
Yep, I'm having trouble. It's going now. Sorry about that. You should see
Oh,
it.
there it goes. Yeah, it wasn't giving me the option either. Thanks for that. I'll give everyone just a moment. All right. So the answer for this one is true. If you have 2 visits in one day, or 2 physicians from the same group, same specialty, both seeing the patient that day, you combine the documentation and bill for just one service. We had a pre-submitted question which asked, if a provider sees a patient in the office and does a direct admit, do they bill for the office visit only and a hospital visit the next day? The answer to that is if you have an office visit and an initial hospital visit on the same day, you would combine the documentation and bill just the initial hospital visit. All right, our next question is a scenario. Dr. Snow provides subsequent inpatient hospital care this morning for Betty. This afternoon, Betty's condition worsens and Dr. Snow provides critical care. The critical care is not payable. True or false? All right, just another minute. I hope you all can't hear my dog snoring in the background. It's the joys of remote work. All right, got a few more getting their answers in. All right, so the answer here is false. In situations where you have an initial or subsequent inpatient hospital service and the patient's condition worsens to where they need critical care later that day, both services may be payable. Modifier 25 would be appended to the critical care if the documentation supports that it is significant and separately identifiable from the hospital inpatient visit earlier that day. So in our scenario, because Betty's condition worsened where she needed critical care later that day, both services may be payable. Now, it does not work the other way around, meaning if Betty received critical care in the morning and Dr. Snow returned for a visit later, both services would not be payable. Dr. Snow would just bill the critical care. All right, our next question is, Dr. Freeze provided initial care for Bobby in observation yesterday. Today, Bobby is admitted to an inpatient hospital stay, and Dr. Freeze provides 40 minutes of care. How does Dr. Freeze bill today's service? Is it A, 99221, B, 99232, C, 99215, or D, 99203? All right, the answer for this one is B, 99232. Changing status from observation to inpatient is not considered a new stay, meaning it does not warrant billing another initial service. Dr. Freeze would bill a subsequent service with 99232. Moving right along. Our next question is, which of the following are billed for 60-minute inpatient service when Betty was admitted and discharged today, and she stayed more than 8 hours? Is it A, 99222, B, 99223, C, 99234, or D, 99235? All right. The answer for this one is C, 99234. And this is because we have a same day admit and discharge, and the length of stay is more than 8 hours. We had a pre-submitted question which just stated discharge summary. The discharge management is the instructions you provide the patient for when they leave that facility. This is not the same as the discharge summary that you put together for the hospital. So your documentation for the discharge stay management would need to show the time spent with the patient and details on the instructions that were provided to that patient for their continued care once they leave that facility. All right, for our next question, we have a scenario. Holly was admitted to the hospital today at 9 a.m. and discharged at 3:30 p.m. Which of the following would Dr. Coco use for his 50-minute service provided to Holly today? Is it A, 99221, B, 99222, C, 99223, or D, 99238? Give you a couple more seconds. We still have a few getting their answers in here. All right, looks like we're kind of split on this one too. So the answer for this one is A, 99221. This is a situation where Holly was admitted and discharged on the same day, but the stay was less than 8 hours. I'm going to go back out to the E&M services guide for just a minute and show you a section that you might find helpful for these types of situations. So I'm going to go back to the bottom of page 13. So this section is all about admit and discharge on the same day. And each of these bullets here, I'm sorry if you hear me, my mouse clinking on my desk, it's, I think, running out of battery. There we go. So each of these bullets here gives you different details on situations that you might see for same day admit and discharge. For example, we have this first bullet here, which tells us that if you admit a patient and discharge that same day, and the stay was less than 8 hours, you would bill with the initial hospital codes 99221 through 99223. So this is like the scenario in our question. Holly was admitted today at 9 a.m. and discharged at 3:30, which is less than 8 hours. So we would use 99221 for a 50-minute service. The next bullet tells us not to report discharge management codes if the stay was less than 8 hours. Then we have the third bullet. This is for admit and discharge on a different day, and you would use the initial care code and a discharge day management code. And then for the last bullet, we have admit and discharge on the same day, but the stay is more than 8 hours. And we would use the hospital care codes for admit and discharge on the same calendar date, 99234 through 99236. Now, what I find most helpful, though, is a table that's on the next page. This kind of sums up each of those bullets, but in a format that I personally find easier to look at. So this breaks it down by the first column based on whether or not the discharge was the same calendar day as the admit or a different day. And then we have the length of stay. So is it less than 8 hours, or was the length of stay 8 hours or more? All right, let's head back to the presentation. Our next question is another scenario. Pablo was admitted Monday at 5 p.m. and Dr. Starr spent 45 minutes providing discharge instructions Tuesday at 8 a.m. Which of the following would Dr. Starr bill to Medicare for Tuesday's service? That may look a little different than your slide if you downloaded the presentation. For Tuesday's service, is it A, 99221, B, 99233, C, 99234, or D, 99239? All right, it looks like most everyone is getting this one right. The answer here is D, 99239, which is the discharge stay management for more than 30 minutes. So if we looked at that table that I showed on the last slide, we find the situation for our scenario, which is discharge on a different calendar date than admission. We have a stay from 5 p.m. to 8 a.m., which is more than 8 hours. And we see that we are able to bill initial hospital services and discharge day management. So for this question, Dr. Starr can bill 99239 for the 45 minutes he spent providing discharge instructions on Tuesday, and could bill one of the initial hospital care codes, 99221 through 99223, for Monday's service. All right, we have a few more questions. Our next question asks, which of the following modifiers identifies the physician who oversees the patient's care from all other physicians who may be furnishing specialty care? Is it A, modifier 57, B, modifier 24, C, modifier FS, or D, modifier AI? Oh, wow, everyone got their answers in super quick on that one. All right, so the answer is modifier D, modifier AI, for the principal physician of record. So modifier AI is an informational modifier which tells Medicare who the admitting or attending physician is that oversees the patient's care while in an inpatient hospital or nursing facility setting. This modifier is only appended to initial care codes. So for initial hospital or observation care, this will be those codes 99221 through 223. I want to go to our WPS modifiers page, which is the last in your list of links for this activity. So here's our modifiers page, which has the most common modifiers organized alphabetically by category, each with a hyperlink to a fact sheet for that modifier. And I'm going to scroll down and want to point out a few things as I get down to that. So first we have this section on evaluation and management modifiers, and there are links to fact sheets for modifiers 24, 25, and 57, which Leanne talked about yesterday. I want to pause for just a minute. We did have a pre-submitted question kind of relating to modifier 25, which asked about wound procedures on the same day as an E&M. If the E&M was significant and separately identifiable from the wound procedure, it may be billed with modifier 25, but you want to make sure your documentation supports that the modifier 25 requirements have been met. If the person who asked this particular question is on today, I encourage you to use the fact sheet here for modifier 25. And we also recently did a webinar on modifier 25, and I've asked Leanne to place a link to the recording in the chat. So also here, we have the modifier FT fact sheet, and we're not going to cover this in this series. This one is specific to critical care. You also have information here on the FS modifier in the correct billing of split shared services link. Now for this question, the fact sheet that I'm going to show you as kind of an example of our modifier fact sheets is down here under initial inpatient hospital and nursing facility modifiers. I'm going to click on the modifier AI fact sheet, and I just want to take a quick look at this one. You see we have on this fact sheet the definition, which is the principal physician of record again. Most of our modifier fact sheets also provide appropriate use and inappropriate use. We also have some additional information here, which just reminds us that AI is an informational only modifier. And then some information on documentation for the AI modifier. So the documentation would need to indicate that the physician is overseeing that patient's care in the inpatient setting. I'm going to head back to our presentation, but again, I encourage you to hang on to the link for our modifiers page to refer back to later if you need those. All right, next we have another scenario. Dr. Green is Peter's principal physician of record. Today, Dr. Foster provides an initial hospital service for Peter. Dr. Foster must append modifier AI to his initial service, true or false. We'll do just a few seconds on this. We have one more question after this, and I want to make sure to respect everyone's time. All right, so the answer on this one is false. In this scenario, Dr. Green is the principal physician of record, and he would be the one to use modifier AI on his initial service. Now, Dr. Foster is another physician involved in that patient's care. Maybe he's a specialist, such as a cardiologist, and can bill for his initial service, but he would not use modifier AI. All right, for the last question. Dr. Glove provided discharge instructions to Patty on 12/16. Patty was not discharged until 12/17. What date of service would Dr. Glove use for discharge management? Is it A, 12/16, B, 12/17, or C, Dr. Glove's service is not covered? I'll go with D. I am ready for spring. Couple seconds on this one. All right, so the answer for this one is A. It would be 12/16. For your discharge day management codes, you'll use the day the discharge instructions were provided to the patient, even if they were not discharged till a later date. All right, that being said, unfortunately, we are just about at the end of our hour. We've included this page here with some resources for you. Out of respect for everyone's time, we will not get to the chat questions today, but I will send out an email to all who attended today with answers to any unanswered chat questions. If you do think of any additional questions, you have 7 days from today to submit those, and you'll send those to our education mailbox. Make sure to include the title of the webinar in the subject line, which is Snow Day Activity, Inpatient Services, and that way they'll make sure those emails come to Leanne and I. Keep in mind that we are not able to access any claims history, so you will want to contact customer service for any claims related questions. Also, in a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. The email contains your certificate of achievement. It will have your name and contact hours if you need to turn that in for credit towards continuing education units. If you do not receive the email, a few things may have happened. You may want to check your spam or junk folder. Also, if you joined by phone only, you would not have received this email, as there's not a way for us to capture your email systematically from the attendance record. No need to worry though. If you joined by phone, you can email us with the phone number you joined with and request your certificate of attendance. And Leanne will be adding that email address to the chat. All right, last thing for you, please take a few minutes to complete the survey. Tell us what you liked, what we can do better, and this is a way that you can suggest topics for future education. You have a couple different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that site is the CMS Qualtrics page. And the prompt will look like the picture we have shown here with the little yellow triangle. We included that image so that you know this is safe. It's not malware or anything like that. All right, that concludes our webinar. On behalf of myself, Leanne, and all of Provider Outreach, we thank you for taking the time to join us. We look forward to your survey feedback and hope to see you again at future events. Everyone stay warm and have a wonderful afternoon. You may now disconnect.